Okay, and here we go. All right, so title of our talk today is Opioid Use Disorder, Diagnosis and Treatment. I have no commercial interest or conflicts of interest for this talk. So what are our goals today? The goals are that at the conclusion of this presentation, the learner will be able to discuss the assessment and diagnosis of opioid use disorder using those DSM-5 text revision criteria, explain the assessment and some treatment options of opioid intoxication, overdose, and withdrawal, identify some options for the treatment of opioid use disorder using both pharmacological and non-pharmacological interventions. So what are opioids? What are we even talking about? So opioids are a class of compounds, both natural and synthetic, that are related to the opiates. Now, the opiates are actually the psychoactive compounds, the alkaloids. They're the natural products of the opium poppy, Papaver somniferum. The natural products of the poppy are morphine and codeine. So these are the substances that you can get directly from the poppy. Now, from those can be derived what we call the semi-synthetic opioids. These are heroin, oxycodone, hydrocodone, hydromorphone, oxymorphone, etc. Now, what we can also do is we can synthesize fully synthetic opioids. So these are chemicals that can actually interact directly with the receptors on the opioid receptors in our brain. So these are created de novo, and they're meant to mimic those kind of natural substances that are found in the poppy, as well as those natural substances that are produced by the human body, the endorphins and the enkephalins. So these include methadone, meperidine, tramadol, fentanyl, and carfentanil. Obviously, some of those names should jump out to you. We're very familiar with those. We also, when we're talking about opioids, we have what we call mixed agonist antagonists. These are chemicals that both activate and block opioid receptors at the same time. These include pentazocine and especially another name that should jump out at us, buprenorphine, which we'll be talking about in a bit. So let's just go through some statistics just to get an idea of how important this situation is. Now, in 2021, last year, there was just about 107,000 drug-involved overdose deaths in the United States. Of those, 80,000 involved opioids. So that means just about 80% of all overdose deaths in America last year were related to opioids. 16,000 of those were from prescription opioids. So these were people either misusing or overdosing on their prescribed opioids. 9,000 of those were from heroin. So, a relatively small percentage of those opioid deaths are actually coming from what we may stereotypically and historically see as the main bad guy in this, heroin. Now, many of those heroin deaths involved fentanyl, because fentanyl is a very high potency opioid that is easy to manufacture, and it's very potent in very small amounts. So we're finding it corrupting a lot of the drugs that you're seeing on the streets. So heroin, some artificial prescription pills that are made, these all contain fentanyl. And fentanyl is highly lethal because it's very easy to overdose on by mistake. Now, 53,000 of those deaths were from stimulants. Now, that's an increase of 13,000 from 2020, and this is largely driven by fentanyl. So again, that corruption of the drug by fentanyl is leading to these increased deaths because a lot of folks don't know that this fentanyl is actually in their methamphetamine. These stimulants also include things like cocaine or general amphetamines, and they can all be corrupted with fentanyl. Now, 12,500 of those deaths were from benzodiazepines. Again, we're seeing a steady increase, and again, this is largely driven by fentanyl. So we're going to be talking about opioid use disorder today. This is the primary DSM-5 diagnosis for opioid use disorder. However, it's important to note that there's actually 5 opioid-related disorders in the DSM-5. Now, in addition to opioid use disorder, we see opioid intoxication, opioid withdrawal, other opioid-induced disorders, and unspecified opioid-related disorder. Now, this talk is going to focus on the first, opioid use disorder. It's worth taking a second just to kind of mention the others. Opioid intoxication is that very specific diagnosis that's related to the signs of intoxication, and we'll be reviewing signs of intoxication, and there's a great deal of overlap there. Likewise, opioid withdrawal is a specific diagnosis if the patient is in opioid withdrawal, and you can apply a DSM-5 diagnosis. We'll be going over those signs. They do largely overlap with the DSM-5 criteria, and where there's a little difference, I'll mention that. The other opioid-induced disorders is in the DSM-5 system, you can actually make a diagnosis of, say, depression, but attribute that to the use of opioids. Likewise with mania or anxiety, et cetera. In that case, that falls under that other opioid-induced disorders diagnosis. And then there's our good old unspecified opioid-related disorder. Just about every DSM-5 criteria has that unspecified category available. So that's where that falls into. This is if there's an opioid use problem, but it does not meet the criteria of opioid use disorder, which, as you're going to see, it's fairly simple to meet opioid use disorder criteria. So I don't think there'd be many that would fall into that category, but it's always there. So what are the DSM-5 criteria for opioid use disorder? The main statement for this diagnosis is a problematic pattern of opioid use leading to clinically significant impairment or distress as manifested by 2 or more of 11 criteria within a 12-month period. Okay, so we're going to break that down and go through that piece by piece. First off is a problematic pattern. What is that problematic pattern? That means compulsive, prolonged self-administration. So this means folks are giving themselves opioids in whatever form. They're administering to themselves. They're not being administered by anybody else. It's compulsive, right? That's an important word. That means that even if folks want to control or stop it, they feel they are unable to. That problematic pattern also includes use for non-medical purposes. So using it as a euphoric medication, basically, in short terms to get yourself high, that is a non-medical purpose. Likewise, in a non-medical manner. So whatever your purpose is, if you are doing an intravenous injection on your own of an opiate, that's considered a non-medical manner because we usually don't have folks give themselves intravenous injections. A problematic pattern could also be that it's prescribed. So there's a diagnosis, it's being legally and appropriately prescribed, but the person receiving it is using it in amounts greater than needed or for the prescribed purpose. So this is if someone is maybe overstating their level of pain for the specific purpose of getting larger amounts of opioids, or if they're given a supply that's meant to last them 2 weeks, but they keep going back to get more and more and more and trying to extend that time frame. So that's kind of the elements of the problematic pattern. Now, after that problematic pattern, there are 11 criteria, and we need to meet 2 or more of these 11 criteria within a 12-month period. Now, as we're going to see, it is very simple to meet these 11 criteria, to meet at least 2 of them. They're going to be very straightforward in anybody with any sort of problematic use of opioids. What are these criteria? Well, there's 11 of them, so it's a big list, and we're going to go through them one by one, but it can really help to kind of chunk them into these 4 different categories. So the categories are impaired control, social impairment, risky use, and a category related to the pharmacological properties of opioids. And we're going to go through each of these in detail. So first, we're talking about impaired control. What does that mean? Well, that can mean that opioids are taken in larger amounts or over a longer period than was intended. And that was part of that problematic pattern, right? This is where you're taking more than you need or for longer than you need or both. It can also be, now again, I'm going to remind you that as we go through these, you only have to meet 2 of these individual. Okay, so the second one is a persistent desire or unsuccessful efforts to cut down or control opioid use. So that means if someone is self-administering opioids, if they're taking them in a larger amount or over a longer period than was intended, and they have a desire or unsuccessful efforts to cut down, you're done. You've just diagnosed opioid use disorder. Now, of course, there's 11 criteria to go through, but that just shows you how simple and straightforward it is to diagnose this disorder. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover from its effects. Now, my primary clinical practice is I'm a sole psychiatric provider for a 100+ bed rural intensive inpatient drug treatment program and residential drug treatment program for pregnant and parenting women. So as I interview my patients, as I talk to them, I get to know them, what really comes through is that they spent so much of their time, especially right before they got to detox and treatment, when they were really at the high point of their use, they were spending all their time just obsessed about getting that opioid, using it, or having to recover from it. It just took over their entire life. And that's what this criteria refers to. The fourth is craving or a strong desire or urge to use opioids. So if someone just has one other criteria plus a craving or desire to urge to use, that meets those DSM-5 criteria for opioid use disorder. Our next category is social impairment. What is this? This is a recurrent opioid use resulting in a failure to fulfill major role obligations at work, at school, at home. So basically, if that opioid use is impacting the patient's ability to do their roles at work or school at home, that is a criteria for opioid use disorder. That means the person is not able to care for their children or family. They're not able to go to work. They're not doing their schoolwork as they're supposed to. Whatever it is, that meets criteria for OUD. Having continued opioid use despite having persistent and recurrent social or interpersonal problems caused by or exacerbated by the effects of opioids. Because of their use of opioids, this person is having these major social or interpersonal problems. They're constantly having a fight with their significant other. Their friends don't want to interact with them because of their use, etc. Important social, occupational, or recreational activities are given up or reduced because of opioid use. So this person used to be an avid churchgoer or an average member of a club, or they used to be an average player of a sport, or they were really involved in aspects of their occupation. And because of their opioid use, they've given up or reduced those activities. That's a criteria for OUD. Our third category is risky use. So this is recurrent opioid use in situations in which it is physically hazardous. So this is driving a car while using. This is operating machinery while using. This is, working on the sides of buildings in a construction job while you're using while you're using opiates rather. That is a risky use. Likewise, continued opioid use despite knowledge of having a persistent recurrent physical or psychological problem that's likely to have been caused or exacerbated by the substance. That means if the person has an illness related to opioid use disorder but keeps using, that's a criteria. Now, prior to becoming a psychiatric nurse practitioner, I was an emergency department nurse practitioner for many years, and we would regularly have patients come in who were injection opioid users, and they would come in with issues ranging from giant abscesses under their skin to life-threatening infections. And you would see them over and over. They would keep coming in, and that is OUD. That is, they were recurring and continually using, even though they were putting their lives at risk very directly because of the effects of their use. Now, lastly, we get to the pharmacological properties of opioids. And what is this? So in specific to the DSM-5, there's two. There's tolerance and withdrawal. Tolerance means you need more and more of the medication to get the same effect, or if you're using the same amount of medication, the effect is less and less. It's basically saying the same thing two different ways. Likewise, withdrawal is if you have kind of this characteristic syndrome, which we're going to go into detail in a little bit. When you stop using opioids, you get these symptoms, which we'll talk about. If you get that classic symptom, that means you have opioid use disorder. That means by stopping them, you have the syndrome. That means you have OUD. Or the person is taking opioids or a related substance in order to avoid those effects. So they're specifically trying to get like loperamide, like the antidiarrheal medication, which has opioid effects, to prevent those withdrawal effects. Now, the exception with these two and why they're starred is that if the person is taking opioids for a legitimate purpose in a legitimate manner, so they're not meeting any of the other criteria. This is your prescribed pain medication, you're a cancer patient or another chronic pain patient or acute pain, but technically you do have tolerance and you do have withdrawal just because of the nature of opioids. If those are the only two you have, you do not meet opioid use disorder. That means if a person is legitimately taking pain medication, legitimately prescribed in the way it's supposed to, even if they have tolerance and withdrawal, that does not count for OUD. So that's one of the exceptions here. Now we have some specifiers, of course, being DSM-5 criteria. So we want to specify, are they in early remission? That's more than 3 months, but less than 12 months. In sustained remission, so no criteria met for more than 12 months. Now the exception to both of these is that criteria 4, if you think back, craving. In other words, you're allowed to still have craving, you can still be considered in remission. So as long as you have no other criteria except for craving, then you meet that criteria for remission. You also specify, are they on maintenance therapy, methadone, buprenorphine, naltrexone, which we'll discuss in a bit. And the exception to this is tolerance and withdrawal. You are allowed to have tolerance and withdrawal and be on maintenance therapy. And also specify, are they in a controlled environment like the practices I work in, where it is, it is a controlled environment that everybody's searched, no one's allowed to bring in opioids. This can be jails, therapeutic communities, et cetera. And then we want a code based on severity, and this is very straightforward. You look at those 11 criteria. If they meet 2, they need to meet 2 for opioid use disorder. So if they meet 2 or 3, it's mild OUD. 4 to 5, it's moderate OUD. And 6 or more, you can call it severe OUD. And then you can go back and add those remission specifiers as we just discussed, if they're applicable. So let's switch gears a little bit and just talk a little bit about the assessment and treatment of opioid use disorder. We're going to be talking primarily in the very acute phase, kind of that early detox phase, but we'll touch on maintenance as well. So first, let's talk about clinical signs of intoxication. These are things like altered mental status. So from euphoria, so getting high, if they're in a very high, a euphoric, they can even be very energetic. That's an altered mental status, and all the way up to lethargy and coma from overdose. Myotic pupils, which are pinpoint pupils, that's a sign of intoxication. Very dilated pupils, mydriasis, that is a sign of overdose. So that can be a sign of OUD in extreme overdose. Because of anoxia, you get that mydriasis. So you do see that. Slowed bowel sounds, normal to low heart rate or blood pressure, hypoventilation or respiratory depression. So these are some signs of clinical intoxication. And I will note that in the actual DSM-5 diagnosis of intoxication, it varies a little bit. It includes the altered mental status, and it also includes those pinpoint pupils. But other than that, it completely focuses on the psychological status of the patient in intoxication. It doesn't really talk about vital signs or other physiological measures. Now, when we're talking about intoxication, what we can say is the absolute worst form of intoxication, and that is overdose. And that's because overdose with opioids can lead to loss of life. It can lead to suppression of the respiration to the point that the patient cannot control their own respirations and they can die. So what is our emergency treatment of this? This is naloxone, brand name Narcan. This is a pure opioid antagonist. It replaces the opioid at the receptor site. What's that mean? It means it knocks off the opioid. So the opioid is sitting there exerting its effects, which can be that euphoria, but it's also going to be that respiratory depression and those other symptoms. So Narcan comes in, knocks that off, and holds that site so the opioid can't come back. And once you knock that opioid off its site, those signs start to reverse, and they reverse rather quickly. This is a medication that's available intravenously, intramuscularly, intranasally. It is worth noting that a lot of the emergency kits are coming with intranasal or naloxone rather. You need a much larger dose, and the response is slower to get the same effect. And we're starting to see more and more kits and cartridges available in some states without prescription. This is a huge boon. This is a huge win for public health. And I think just having these as ubiquitous as we do AEDs so that we can intervene in issues of cardiovascular failure, if we can do the same for overdose, I know we're going to prevent a lot of loss of life. Talking about Narcan some more, the dosing really depends on the clinical presentation. It can be from 0.4 milligrams up to 5 to 10. Now, the larger doses will push the person into profound withdrawal. Now, if you find someone down on the street and you're using Narcan on them, you just want to give them as big a dose as you have access to try to reverse that and get their breathing back. But it's important to know, especially in the clinical setting, our goal really is adequate ventilation. We're not trying to wake the person up. We're not trying to give them Narcan because they're obtunded, they're comatose, they're out, whatever. You give it to them, you're not trying to get them to jump up and say hello. You just want them to suddenly start breathing on their own. That's what we're trying to reverse. Because if you go too far, you're going to knock them into a very unpleasant, very, very painful withdrawal symptom. Now, if it's saving their life immediately, yes, that's more important. But if we can titrate as we can in clinical settings, we really want to do that. And depending on the opioid half-life, the drug may outlast the Narcan. This means that you give the Narcan, it reverses that respiratory depression, but the Narcan can wear off before the opioid if it's a long-acting opioid, in which case you want to watch that because they'll get their breathing back, they'll still be kind of out of it a bit, and then that breathing will go away again, so you may need to redose. So speaking of withdrawal, right, we just talked about Narcan pushing patients into withdrawal. So what are these signs of withdrawal, which can happen with Narcan or just naturally from stopping opioids? So they kind of form a complex picture of where those opioid receptors are. Now, there's a lot of gastrointestinal distress, including abdominal cramps, diarrhea, nausea, vomiting. Flu-like symptoms, so you get that lacrimation, so that tearing, runny nose, sweating, shivering, goosebumps. And then a whole bunch of sympathetic responses and central nervous arousal responses. That's dilated pupils, right? So remember, pinpoint pupils was intoxication. And one important and easy way to remember those signs of withdrawal is they are going to be pretty much the diametric opposite of the signs that you see in opioid intoxication, right? So opiates cause severe constipation. Well, when you stop, you're going to see diarrhea. Opioids cause like a lot of kind of flattening of the sympathetic response. So they dry you out a little bit. You're not seeing a lot of runny nose, tearing, sweating and shivering. You take them away and you get that sympathetic arousal and you start seeing those signs. Likewise, it was dropping blood pressure a little bit. So you get a little hypertension, you get an increased heart rate. They go from being, sedate or in a pleasant mood to anxious, irritable. They can't sleep. They're agitated. They have restless legs. They're restless. They tremor. So you can see that's just that opposite where you get this arousal when before the opiates were kind of being a general depressant and causing euphoria. And then you see yawning. That's a very clear sign of opioid withdrawal. They do a lot of yawning, sneezing, anorexia. They just don't want to eat. Dizzy, a lot of body aches, muscle aches, joint aches, and leg cramps. So you see a lot of kind of just physical malaise, and they just physically feel terrible. Now, how do you manage these withdrawal symptoms? Now, the symptoms are going to last in relation to the half-life of the ingested opiate. So short-acting opiates going to have some very severe withdrawal symptoms that tend to wear off fairly quick. Long-acting, they may be milder withdrawal symptoms, but they're going to last longer. Now, generally, withdrawal from opioids is not life-threatening, especially even including what we'd call cold turkey, just stopping. One possible exception to this is if you're precipitating it by naloxone. So if you're giving someone that was especially a heavy opioid user and you give them a huge dose of naloxone, that can be such a change to their system that we do see in the literature some life-threatening autonomic instability. You can see some delirium. It's much, much, much more rare. Now, life-threatening results from withdrawal from, say, alcohol or from benzodiazepines can be life-threatening, and it's not as rare. But with opioids, it's much rarer. But it's something to know about and be aware of. And that's, again, when we're in the clinical setting, we don't want to just blast them with the Narcan. We want to titrate it to get that respirations back, but not too much farther than that. Now, how do we validate withdrawal symptoms? Well, we use the COWS, the Clinical Opiate Withdrawal Scale. This is an 11-item scale that quantifies some symptoms of withdrawal. So let's take a look at that. Just know your COWS categories and know the score. 5 to 12 is mild withdrawal, 13 to 24 is moderate, 25 to 36 is moderately severe, greater than 36 is severe. One important use of the COWS scale is that when we're implementing buprenorphine, which we'll talk in a little bit, when we use that as a medication to handle withdrawal and even to be a maintenance medication to prevent further opioid use, we want the patients in moderate withdrawal when we actually give them the medication so that we're not actually inducing a worse withdrawal, we're actually treating a withdrawal that's already there. So let's talk about those withdrawal symptoms with some actual medications, okay? The first and the oldest is methadone. Now, methadone is a full mu receptor agonist, just like heroin, just like morphine. It's a full agonist. It's long acting. It has a very long half-life. And what that means is it occupies those sites longer, and any sort of euphoric or negative effects are much gentler. It's not that big spike. So we use it for management of withdrawal symptoms because if you give it, it will relieve that withdrawal without causing a lot of euphoria, without causing a lot of that kind of reward behavior we see with the other opioids. We have to be careful. It's lethal in overdose. It can cause lethal cardiac arrhythmias, so we only give it in supervised settings. In general, methadone and buprenorphine are effective for treatment of withdrawal symptoms. There's another medication, an alpha-2 agonist called clonidine that we can use that's not an opioid. It's very effective for treating symptoms, but methadone and buprenorphine really are the most effective. It's good to realize, and this isn't necessarily negative or positive, but just something to keep in mind. Patients that are on methadone or on buprenorphine, they remain opioid dependent, okay? So we have not cured their opioid use disorder, if that's even possible. They may be in remission, but it's being controlled by another opioid. So again, this isn't a value judgment. This isn't saying good or bad. It's just something to always keep in mind. That patient is still opioid dependent. They're just like an insulin dependent diabetic, where a diabetic may be well controlled if they're getting their insulin, but they're dependent on that insulin. You can't take it away. That's basically the same thing that happens with opioid dependency. So talking about buprenorphine, the brand name of buprenorphine by itself is Subutex. When you combine it with naltrexone, it's Suboxone. This is a partial mu opioid agonist and antagonist, has a long half-life. So what does this mean? It does do a partial agonism of those sites. So it takes care of withdrawal symptoms. We also use it in maintenance to prevent exacerbations of opioid use disorder. Basically, they don't have that same level of craving because we're occupying those sites, but they're not getting those big highs because it's only a partial agonist. The naltrexone does nothing in the sublingual formulation. So Suboxone is generally a sublingual tablet, so it's either a film or a tablet that dissolves in its mouth, in the patient's mouth. The naltrexone does nothing for that. The naltrexone is there that if the patient tries to break it down and inject it or sell it to someone that's going to inject it, which definitely does happen if they're going to divert it for that, at that point, the naloxone becomes active and they get absolutely nothing from that injection. And in fact, if they're using other opiates, it will push them into withdrawal. So it's a trick for diversion prevention. It's that patients know, don't even bother trying to inject this because not only is it not going to get you high, it may actually push you into an unpleasant withdrawal. The difference between buprenorphine and methadone is we can actually prescribe and administer this through an outpatient program. And it used to be you needed the special data waiver, the DEA waiver that we all got, that you had to go through special classes, et cetera. That's been taken away. And so physician associates, nurse practitioners, and physicians, it's now much easier to prescribe buprenorphine. You just have to take some classes. I think they're working out, because that's a new change. So they're working out the exact requirements at this time. Just bear in mind the patient needs to be in moderate withdrawal before the buprenorphine is started, as I discussed before. So let's just wrap up with some treatment considerations for opioid use disorder. What do we want altogether? We want a calm, quiet environment and a supportive and reassuring staff. And that is because you're not going to change those withdrawal symptoms the person goes through, the diarrhea, the vomiting, the anxiety, the malaise, but the quiet environment can really improve a lot of the worst of those symptoms so that that anxiety isn't as bad, et cetera. Again, I deal with this all the time because I'm overseeing these sites via telepsychiatry. And when the census gets pretty big, or, we're a little light on staffing, my patients come and they tell me, like, it's terrible right now. I'm so anxious. I'm so, I just can't relax. I can't sleep because there's so many people here. One of my units is pregnant and parenting women. So they'll say, boy, everybody's got their kids here. So that really makes a very big difference. And I've seen that in my own practice. And it can just decrease the need for pharmacological interventions. When things are going great, I have patients telling me they really want to start weaning down on their methadone, their buprenorphine. They don't need as much anxiety medicine, et cetera, because they're actually feeling calmer themselves. So it makes a big difference. We have some psychotherapeutic options. There's good old cognitive behavioral therapy specific for substance use disorder. Contingency management, this is just a fancy way of saying that you tell if you stay off the substance for a certain amount of time, you will get certain rewards, including monetary. And they're doing this in more and more places. And again, it may be a bit controversial, but the literature shows it's very effective. We have good 12-step facilitation. This is your classic Alcoholics Anonymous, Narcotics Anonymous, et cetera, proven over many, many years to be effective due to that social interaction aspect, the peer aspect. So being able to talk to someone that's been through OUD is very impactful. Addiction counseling, so one-on-one psychotherapy and counseling geared directly towards addiction is hugely effective and very important. And then family therapy, because these problems don't just arise out of nowhere. They come in the context of family issues, et cetera. So some concluding thoughts. What is the most effective treatment? From what we can see right now, it's that medically assisted treatment, especially methadone or buprenorphine or other medications, plus that therapeutic program. You kind of need both. The program alone without the drugs is less likely to keep a person off illicit opioids. The medication assisted treatment is probably a little more effective, comparatively by itself than program by itself, but it definitely works if it's a package altogether. We have effective pharmacological treatments. Strong social support is just non-negotiable. If it's a 12-step program, friends, family, a community, these folks really need community support. Fentanyl is an increasing cause of mortality in opioid use disorder and substance use disorder. It can't be ignored. It is a major, major issue. It's taking a chronic substance use disorder and making it fatal. So we really have to be aware and watch out for it. And we need to just watch out for this in any mental health setting. I don't care if you work in substance use or not. I don't care if you only work in pediatrics, if you only work in geriatrics and psychiatry. You are going to see opioid use disorder and substance use disorder in some form in any mental health setting. So make sure you educate yourself, make sure you're knowledgeable about it, and make sure that you're prepared to at least address and treat and refer as appropriate. And that is it. That's my references. Thank you so much. I hope you found this useful. And I appreciate your attention. Thank you.